Welcome to Orthopod, a podcast about the people of orthopedics and their stories. We understand that we all play many roles in our careers and lives, and it is these very stories that ultimately inform our successes and failures. Hi, it's Mo Bendari from Orthopod, and today we have a very interesting session. We're going to be able to talk with a resident and orthopedic surgeon about burnout. And if you haven't thought about burnout, in fact, it may be too late. And so what we're going to try to do is get you thinking about it, get you understanding it, and hopefully giving you some insights. I, myself, personally, have lots of questions, but I think what we'll do is use our usual format. And our usual format begins with introducing our first guest, and I'll let him introduce himself. Collin.
Sure. Hi, my name is Collin McCarthy. I'm a PGY5 resident at McMaster University. I'm currently finishing up my residency. I'll be starting my fellowship in hip and knee arthroplasty at the Brigham and Women's Hospital in Boston. Very excited about that. And I first got my start in wellness from a resident perspective through the Professional Association of Residents of Ontario, and then again through Resident Doctors of Canada. It's an issue that's very near and dear to my heart, as I've seen multiple trainees come through, multiple staff members come through, and it was one of those things where we're really great at advocating for our patients. We'll lay down in traffic for them. We'll do literally everything that we can. But when it comes to advocating for ourselves, for some reason, all of a sudden these tigers of physicians become shy little sheep. It's the most interesting thing.
Let me ask you this. So, I think I have a pretty good understanding, and I think we all do have this general implicit understanding of what we think burnout is. Do you have a definition or some sort of general metric we can say, okay, this is what we think burnout is as a starting point?
Sure, yeah. There's a great definition, the Maslach Burnout Inventory, which uses the traditional definition of emotional exhaustion, depersonalization, and a decreased sense of personal and self-accomplishment. But what does that mean on a day-to-day basis? It's much more difficult to discern.
Right.
It's one of those things where when you're looking at art, it's hard to define, but it's easy to spot.
Yeah.
And burnout from the same way. It's that physician that you see in the hallway that used to be smiling, that really was a great patient advocate, that had a smile, and all of a sudden that smile sort of slowly fades away.
Right. So you mentioned that you got started in this on a personal journey, and you were introduced in it through personal health and well-being. Was there a specific moment where you thought, this has become real for me as you personally? And if it is that how you started seeking knowledge about it? Or has it been more about awareness, and then through awareness you realize that you're at risk?
It started for me with a personal moment where PGY1, I was sitting there looking at my apartment window.
Yep.
I was on home call, I got a page, I had to go back in, and I was wondering if I wanted to be a doctor.
Yep.
Not if I wanted to be a surgeon, not if I wanted to transfer programs. It was the first time in my training where I was genuinely jealous of my friends who weren't physicians.
Right.
And I spent my entire life up until that year desperate to become a physician.
Right.
So I didn't know how I got there, and I had that brief moment of insight as to why did this happen.
Right.
And I actually spoke with Dale Williams about it. He was one of our staff surgeons at the Hamilton General. I was not his resident, but he was one of the staff that we all looked up to. And he said that at one point or another, we all feel this way. Training is difficult, the hours are long, it's everything that we're doing for the patients always feels so of the utmost importance. And it's difficult to bear that responsibility, and how you respond to it, how you prioritize it, and how you find your own time really makes all the difference whether or not this is a worthwhile endeavor for you.
So let me ask you this. So you have this moment, a pretty critical moment, and I can guarantee that there probably isn't a trainee, and probably even outside, when it comes to medicine, anyone in their jobs, there's a point in which you look at your life and you think, is this what it's meant to be? And you look for switch. In fact, one of our early podcasts, the first one with Dr. Brad Pettersver, we talked a lot about transitions and what it means and, fulfillment. But when you have it as a trainee, you have a job, you have an expectation, you've had this moment. Did you talk to anyone about it? And if you did, how difficult was that? And did the response help you, or did it further alienate you? And this is I'm trying to get to the storyline as we kind of dig deeper.
Yeah, I had that sort of moment where I started openly talking about it to more of my colleagues, whether it was the staff surgeons. I mentioned it to Dr. Pettersver, I mentioned it to Dr. Williams, I mentioned it to my colleagues that were in the program. And the common thread was everyone at one point or another had those moments where they thought about doing something else. And everyone's general narrative of getting into medicine, for me, I was a college dropout. I did search and rescue for Hurricane Katrina. All I wanted to do when I got back was to get into surgery. So it was sort of this mind-blowing moment that I might have wanted something else.
Okay.
And talking to these other people, these other role models that I had, my colleagues, hearing them talk about that this was also something that they went through made me not feel isolated in this. So it made it less of a, is there something wrong with me, and more of a, why is this a shared experience moment?
Got it. And when doing so, you obviously realize I got to do some more reading on this, I got to learn more about it. And quite frankly, I'm going to start interacting with people who are similar minded. So on that note, we should see if we should introduce another guest onto the podcast that I think you connected with and can provide more insight to this topic. So I'd like to welcome to Orthopod Dr. Kerry Collin. Dr. Kerry Collin is a pediatric orthopedic surgeon at the Royal Children's Hospital in Melbourne. And she'll tell you a little bit more about herself. But welcome, Kerry, to the Orthopod podcast. And thank you very much for spending a bit of time with us. So maybe you can give us a brief introduction and a little bit of a rationale as to how you got into the area of burnout research.
Yeah. So in terms of my background, I spent, before I came back to Melbourne, where I originally did my fellowship, I spent 7 years working in the community in southern Alberta. So treating, community trauma and pediatric adult limb deformity. And during that time, I actually ended up joining the board of the medical regulators, the College of Physicians of Alberta. And my original rationale in joining wasn't over the burnout issue, but it became very evident during that time that this, even the college complaints, the medical regulator complaints was made a huge impact on physician health. And I don't know if you saw, there was an article that came out a couple of years ago now, or two and a half years ago now. There was an anesthesiologist from the UK whose wife was a GP, and he had got a medical regulator complaint in the UK just before he left for New Zealand. And it was a 5-month process for him to be cleared. In the end, he was, but it actually kind of made him spiral into depression and a lot of trouble. He ended up ending his life. And I was on the board of the medical regulator at that time. I thought, 5 months is really not that long to get through a college complaint. What are we doing? And so I think it was from that, I just became very compelled in terms of an urgency in this and saying, like, hey, what can we do? And at that time, we didn't really even know where we stood in Canada in the orthopedic, area in terms of, what were our rates of burnout, what was our risk of these things. So that's my background with this area. Yeah.
So I was just talking to Collin about, definitions of burnout. And I think, for most of the Orthopod listeners, the membership of Ortho Evidence, I think we often think of it in some degree. I think I also think of it probably erroneously as the end. It is like, I'm just done. I'm going to quit. It's I think you had said it before we got on air, which is, I'm right at the edge. And is that when we recognize burnout, or do you look at it as a different, more of a spectrum of issues that ultimately lead to a very, very, potentially in some cases, a very unfortunate health state?
Yeah, well, I mean, certainly that we don't want people to get to the point where they actually have to abruptly stop. And that's actually fairly rare for surgeons. I mean, we kind of just carry on and, we shackle up and we just kind of get it done. And so I think a lot of us are just sort of working in this, we're detached, we're cynical, but we don't experience much joy in the work that we do. And so, we're not at the end where we're like, oh my goodness, like I have to stop working, right? And so many of us, and certainly our results from the Canadian Orthopedics survey, which we'll talk about, I'm sure, show that, the majority of respondents, were like distressed. So
like a minority. So why don't you tell us about that survey then? So this is a survey to orthopedic surgeons in Canada.
Yeah, so this was done in November 2018 in partnership with the Canadian Orthopedic Association Continuing Professional Development Committee. And we sent this survey, and it was 2 different formats, one to trainees, so residents and fellows, and one to consultants, like attending surgeons. So sent to everyone. And we found actually surprisingly that 55% of the attendings actually met criteria for distress using a validated screening tool, which was shocking. We figured that the resident rate would be up there. Resident rate was about 40%, and that would be consistent with other published studies. But I think we were just really taken aback at how many people were affected and in a very distressed, scoring like highly distressed scores.
Yeah.
So anyway, so that was presented in the Montreal meeting this past June, and it's pending publication with Canadian Journal of Surgery, actually.
So let me jump in here, and I'm going to ask Collin this question, but jump in to Kerry on your insights on this. But so if we now identify, and it's becoming more and more awareness around the fact that we're seeing, more people are at risk. I'll say at risk, or maybe I'll use the word subclinical sense of burnout, where you don't think you think you're managing, but in fact, evidence would suggest you're not managing, and if you don't find a strategy, you're in trouble. Are there intervention strategies? What is the target here? Is it to get residents to be aware that, hey, you should first be aware, or is it more about should we be introducing health and well-being strategies at the same time? What's the priority for us in this area?
For Collin or me?
Well, whoever wants to jump in. He looks like he's deferring to you. So why don't you start? I'll let Collin jump in.
So I mean, 2 years ago, the discussion around burnout was all in terms of like personal resilience, like, oh, you got to do more yoga and meditation, and it was all on the individual, and that's out now. I mean, well, I'm not going to say it's totally out, but there is a role in for that. But it's really focusing on the system issues, in terms of what can be done to, avoid burnout for workers, right? So, those things are including, a strong and supportive, fair leadership, getting exercise, having a mentor, spending time with family. There's lots of things that we have evidence now for. So I think there's obviously a role for making people aware of this. But then, okay, you can make people aware all day, but if the system is really stacked against you to help, stacked against you, then that's not helpful, right? And so we're still in this sort of awareness, I think, zone. But really, those of us are sort of involved with this quite a lot. We're really calling for more system change and accountability, and in terms of even measurement within our organizations. There's a role for personal measurement. There are tools out there for that, but also for organizations, for hospitals. How are your workers doing? Are your workers all burned out? I would probably want to know that if I was a CEO, right? So, or chief medical officer. So. I think this transition's happening. We're not totally sure, obviously, how to totally solve it. For me, I think one of the things I've sort of come across more recently is how to embrace this sort of joy in work concept. Looking for the places in work that can give you joy, that you can bring joy to others, and how that is very fulfilling and meaningful. So
okay. That's really helpful. So, Collin, you've just heard Dr. Collis's general take on the issue. What do you add to this? So you've been going through that process. I'm sure you've been working with other residents who are probably confiding in you that they're having similar situations. You're talking to folks, probably faculty members. What strategies do you believe, based on the list of evidence-based strategies that you've probably read about and you've just heard, seem to work?
From what I've seen on a personal day-to-day basis, is the first step. And this is going to sound super out of the AA handbook, is recognizing that there is a problem.
So recognize there's a problem.
Recognize that there is a problem, recognizing that it's okay to talk about it. If you recognize you have a problem and you feel like there's no safe place to go to, no safe venue to discuss it, in a lot of ways, in my opinion, that sort of sends you down a cyclic depressive cycle, or a more distressing cycle. It's part of, at least in Canada, an accreditation criterion for every university to have a wellness office that you can reach out.
Okay, so you're not going. So you're looking to say that possibly there should be somebody outside the own job field. So it shouldn't be going to an orthopedic mentor as not say shouldn't be, but it's unlikely that person is the primary target. It's going to be a health and welfare officer. I would have thought you'd want to educate the surgeons to say, if someone comes to you, you should be ready to respond in a way. And I guess the question would be, what would be someone's initial response? So you go and relay it, and maybe I'll go back to Kerry about this. Kerry, so a resident comes up and relays, as Collin, suggests that, I'm feeling, I'll use the word burnt out generically, but things aren't going well. What would you anticipate, or what should be the response to that resident from a mentor?
support, like listen, that's the biggest thing, rather than trying to like fix it all right away. Like obviously, like just really hear them out and try to figure out what the reasons were. Cause I mean, in many times, is that resident having even problems with your peer group, right? Because we know that a supportive work environment, especially a close working group with colleagues, if you have like a best buddy at work or whatnot, I mean, that is protective against burnout. So, has there been a relational falling out with the members of the peer group and the residency group? Are they getting bullied? Is there are they victims of some disruptive physician behavior? Or in some cases, maybe it could be that there's personal stressors, they're having marital trouble or those kind of things. And so I think depending on what the issue is, the solution is going to be different. I mean, some of that, I think it's important to be very supportive as a colleague or mentor or leader. There is obviously that role as well for clearly professional assistance for this person. I think those two go really hand in hand. And in Canada, at least, there's good resources to help trainees for that. So, yeah.
That's pretty good. Okay. So, Colin, do you want to add to anything?
Yeah, I think the point that we're sort of getting to is there's a lot of formalized resources out there. There's the wellness office, there's the accreditation mandated individuals, but as surgeons, our first look is going to be towards that co-resident that you work with every day, that
so
faculty member you have
idea, right?
Yeah. And I think one of the big holes in terms of our prevention and our resiliency training is how do you be that person? So if I were to come to you, Dr. Van Darmy, like, listen, my wife just had a kid 3 weeks ago. I don't know what to do. She's not sleeping. I'm not sleeping. I'm on call. And you were to tell me, like, I've been through this. I've had a similar experience. This is what it was like when I was doing this situation.
Right.
Or just sort of generally understanding how does one start that conversation and keep it open is the important thing.
Okay, that's very helpful. Thank you. One thing you mentioned, Kerry, that I did have a chance to read recently, and you'd sent some really interesting literature to take a look at. But there's a paper, and I'm not going to go to the detail of it, but I know you'll both know about it, Career Fit and Burnout among Academic Faculty. And really the bottom line that I got from it is that if you get people doing stuff they're passionate about and like, they're going to enjoy work a lot better. Now that seems like, kind of pie in the sky, which is, the reality is not every part of work is always going to be, the most enjoyable. But I guess how is it if you recognize you're in a situation, and I think I would be shocked if there isn't an orthopedic trainee or a clinical trainee or someone in their life, I mean, broadly speaking, outside of medicine, that doesn't sit down at some point and reevaluate just why they're doing what they're doing. And they have that moment of either resilience where they're going to figure it out, or they head down another path, the path that you would probably, ultimately typify as being the path to a burnout situation. Are there ways, if you recognize you're in that situation, is it too much of a fantasy to think that you can only do what you love at work? I guess is the question, right? The whole issue of passion, and if you're passionate about the work you do, it, quote, doesn't feel like work and you're enjoying it. So there are going to be aspects of our day that we really, really love, and there are going to be aspects of our day that is purely work. And for some people, I imagine it's the administration part they don't like. But for some, they love the administration. It's the other part. So, I'm giving an example here. Are there strategies or are there places someone can go to figure this out? And maybe I'm getting too granular, but it does seem to be a fundamental goal of trying to be happy and avoid, as a preemptive strategy, is to figure out your purpose and some degree the joys you have in your daily life. And I don't mean work, and work is one of them. There may be other parts of life balance that you consider, but is there a broader sense to handling all this?
Yeah, I mean, that study that you mentioned, it was a group of internists. I think it was at Mayo Clinic. So, it's applicable. I mean, it's hard to say whether we can apply it broadly, but certainly, the guts behind that was, if your thing is doing admin, you should be trying to do that 20% of the time. If your thing that you love, that gives you joy, is research, then you should be doing that, at least 20% of the time. That being said, like for me, like I quite like administration, but do I want to do administration 100% of the time? Absolutely not. I mean, that would probably shred me, right? So, I think if you can kind of aim for that 20%-ish area, I mean, at the end of the day, we still need some of us have like 100% academic appointments and maybe aren't doing clinical medicine anymore. If that's the route we've chosen. Most of us still have to see, patients, and most of us do get meaning out of seeing those individual patients, right? So I think that the key is knowing yourself, knowing what makes you happy, what gives you joy, what gives you meaning, and trying to kind of focus on ramping up those areas if you can, or really advocating for yourself with your, in your institution. Like, I really want to do this. This makes me happy. And also leaders, like faculty or department leaders, really need to be asking that of their staff. Like, what gives you joy? What gives you meaning? How can I help with that? Because you're going to have a more engaged, effective worker if you're actually able to cater to that.
Well, let me ask you this. So you interact with this topic to lots, both, and it looks like you've been strong advocates and you've been trying to create awareness, and you're obviously producing research as well to help inform the situation. What do you feel is the most underappreciated aspect of the research you do among the communities in which you're trying to do it? So you're both in orthopedic. So in the orthopedic or broader medical community, what do you think is the biggest misperception about burnout? Or among the bigger misperceptions about burnout?
Doesn't affect me.
Yeah.
Not my problem.
Okay.
Yeah. Not me. Yeah, that's the biggest misperception.
So when you have that person who says, okay, well, clearly you have this issue, I don't, how do you, is that just an end door? There must be strategies that one might use to first self-evaluate. And if they think they have someone watching this podcast says, I think I have a colleague who could use this, but that colleague is likely to be defensive. What would be is there any sort of tool, any sort of resource that we can?
So there is a free online resource. It's through MedWeb Solutions. Okay, so that's it was Mayo. It's from the Mayo. Okay, so I have to say that it's from MedWeb. Okay, and it's called Physician Wellbeing Index. Okay. And so Physician Wellbeing Index. So if you just Google that, you can go, and then you can pick, and there's ones that are validated for medical students, trainees, attendings, and so that is it's less than 2 minutes. It takes a minute to complete, literally. And so that's what we ended up using for our Canadian study, because we figured we'd have a higher completion rate rather than the formal NASLAC burnout inventory, which is 15 minutes to complete, which no orthopedic surgeon is going to do, right? Okay. So if you could just, whip that out, take it yourself, whip it out, to your colleagues, say, hey, I took this, I actually, wasn't as great as I thought. What do you think? And I bet you they'll do it because it's so quick, right? Okay,
so that's actually it. So what we'll do is we'll make sure we provide that link to, in the storyline for this podcast, and we'll make sure we make that available, because I think that's a very helpful thing. If I were to ask you kind of I'll get you to both answer this one, but I'll start with you, Collin. Sure. What advice, I guess in this case, if you have to give advice to the viewership, whoever watches this, right? What message do you want to give them about burnout? What would be the message that you want to convey to that group? Sure. And I'll ask you as well after this, Kerry.
There's a couple of different angles to take from this, and the one that I've always sort of found makes the biggest difference is when people think about burnout, they think about themselves at the center of burnout, and is this me or not? The thing that we're often missing with physicians is we tend to be very egocentric. The rates of burnout among resident spouses is the same as the rate of burnout among staff physicians. So it's not just me. My wife is at risk of burnout as well. My children are at risk of burnout as well. When they survey the kids of physicians, they're asking them not necessarily that you spend more time with me, because families tend to be tremendously understanding of what you need to do, the sacrifices that we make as a collective, but they want you to be more present when you're home. Right. So as physicians, we try to excel and do everything to the best of our abilities, and we tend to let our work life bleed into our personal lives. Draw those lines. Become the best father, best mother that you can. Become the best partner to your spouse. Find something outside of work that brings you joy. Become the best cyclist that you can do. And then when you're at work, be the best surgeon that you can be. Truly care for your patients. When you're studying, be the best studier. Be the best at whatever it is that you're doing, but don't spread yourself too thin.
Yeah, so I think you're kind of saying stay in the moment and also have a diversity of I wouldn't say interests, but opportunities that keep you kind of level, right? And there's always the buckets of things that make you fulfilled in life. Yeah. Okay, that's great. Thank you. Kerry, any thoughts on your point?
I mean, again, this seems to change with time for me in many ways, but I've been sort of lately focusing on, what I can do from a cultural standpoint, for instance, in my department, right? And certainly that's in previous jobs, that's also been something near and dear to my heart. And a lot of that, involves community, breaking bread together, actually, helping to foster the environment so people can get to know each other and really get support to each other, because that is free. That resource is free. Each other are free. And also trying to just kind of lead by example and just, show vulnerability and talk about this with trainees and with other consultants. And that is an email format. I mean, certainly after presenting this data, like from our Canadian study, seem to be getting lots and lots of requests or people coming to me. And also I had that also when I was on the medical regulator in Alberta, like, I'd get phone calls like from random physicians, like, help me, like, what should I do? Right. And so, I think just putting yourself out there and as well, like all of us can show that we're champions for this and try to support our colleagues. And that's my thing right now, but
no,
that might have a different focus in another year, but that's what I'm working on.
Well, I think that's great. And, it's incredible how quickly time flies. And, we've basically in a very short period of time been able to, I think, share and get insights from both of you around burnout. I think the fact that we're simply talking about it is the first important step. And I would put out to the viewers here on Ortho Evidence and Orthopod to take a look seriously at the resources that have been provided. And I presume that, they can get in touch with you if there's anyone who has a specific question. Maybe we might, leave some sort of contact, either an email or some generic contact that we can get folks to contact you if they have interest in learning more or about getting specific resources. On that note, I'd like to thank you both for taking time out of your busy days to help us think about this. And I hope you a very restful, peaceful, enjoyable day. Thank you both. Thanks for watching Orthopod. Stay tuned for more episodes.